So I was commencing with my thanks to the organisation and mentioning the enormity of the COVID pandemic, the people who have lost their lives and the staff who have been in the front line, and how the changes from the pandemic will remain with us forever. Teleconsultations, webinars, those sorts of things. Now, periocular malignancy can be relatively straightforward, but it can also be very complicated. We have a number of eyelid tumours that we see: basal cell carcinoma, cutaneous squamous cell carcinoma, sebaceous carcinoma, melanoma, Merkel cell tumours, and many more rare tumours. But all of these actually share common tumour pathways. And most of these pathways work by mechanisms where they avoid apoptosis. They sustain proliferative signalling. They try to gain replicative immortality. They evade growth suppressors, and this leads to an induction of angiogenesis, invasion, and metastasis. If we look at BCCs, the aberrant hedgehog signaling pathway drives BCC formation, and that is facilitated by the Wnt and the Notch pathways. And mTOR and Hippo are also involved. With SCC, epithelial growth factor is one important pathway. P53, the RAS oncogenes, these are all important pathways. Sebaceous is a little bit more difficult. It has many of the same pathways, but it also involves the RB1 mutations, various Wnt and B-catenin pathways, and of course, the DNA mismatch repair enzymes that link this into the Muir-Torre syndrome, MLH, MSH2, MSH6, and PMS2. Melanoma, it adopts similar pathways to the other tumours which have been utilised in targeted therapy management. Merkel cell is a little bit more difficult. It has a lesser understanding of its pathways, but interestingly, there is a viral vector, the Merkel cell polyoma virus, which is involved in 80% of virus-positive Merkel cells around the world, except for Australia, where the percentage is reversed, and we have 80% virus-negative Merkel cells, and that's because of our UV exposure. Now, targeted therapy is treatment that is directed to identify and attack specific cancer cells, but with less damage to normal cells. Generally, it will act by blocking enzymes, proteins, molecules that are involved in the growth or spread of cancer cells, and it enhances the immune system to actively kill cancer cells. And compared to our standard chemotherapy agents, it's a better treatment with fewer side effects. Most commonly, these are small molecule inhibitors. And interestingly, these small molecules have a short half-life and require an oral administration, usually daily. In theory, they should be cheaper than most other agents because it's a standard chemical process to manufacture them. Also, they're actively metabolized by the cytochrome P450 system, so they're broken down quickly. So that's why they need to have generally a daily dose. Whereas monoclonal antibodies have a longer half-life, they're denatured in the gastrointestinal system, they require IV administration, and they avoid cytochrome P450 metabolism. And unfortunately, they're more expensive because of the expensive bioengineering that is required to make them. And there are also kinase inhibitors and other agents that contribute to the targeted therapy spectrum. We all have a normal immune response, and this essentially has two signals. The cytotoxic T lymphocytes, the CTLs, protein binds to the major histocompatibility molecule. CD28 binds with a number of ligands, CD80 or 86, and that is on the target cell. But to get a sustained, robust response to target cell death, cytokine secretion, and the formation of memory cells, that second stage needs to be developed. Now, there are also inhibitory CTLA4 and PD or program death checkpoints that can turn this important process off. So checkpoint inhibitors, which we now use, turn this process back on. And chimeric antigen receptor target cells or therapy causes an antigen-driven cell death. And this is very important in battling cancer today. There are a number of drugs targeting the Hedgehog pathway, but the two that have become FDA approved are vismodegib and sunitinib, small molecule SMO inhibitors. They have a profound metastatic and local response, but unfortunately, both of them do have side effects which can cause problems with their use. The reason that vismodegib is so important around the eye is that it can save eyes that would be otherwise lost. And this has been highlighted by Alon Kahana, Beta Esmaili, and other groups who have demonstrated this. This is a gentleman who on slide left has an extensive basal cell carcinoma invading his orbit. And on slide right, we can see the amazing immune response 3 months after commencing vismodegib. We can see on the MRI, slide left, the extensive medial canthal orbital involvement, which has largely disappeared on slide right. This lady had a recurrent basal cell carcinoma of the left lower eyelid invading the orbit extensively. Here she is in February 2018 before treatment. This is the aggressive, invasive, morphaic pathology. She was commenced on vismodegib. The tumour began to shrink. And in November 2018 was much smaller and led to a decision to proceed with a globe sparing operation where we excised the tumour, obtained clear margins and reconstructed the defect. The histology post-vismodegib, however, was still quite active with a high Chi67 ratio and fairly aggressive mitotic pathology. And I think that highlights that many people feel that vismodegib is a tumour static drug rather than a tumoricidal. And here she is following her repair. We've recently published in an international series a small number of patients, 13, a number of which were mine, 7 of whom had orbital involvement. 40% had a complete response to this treatment. 60% had a partial response, but almost everyone had significant side effects that caused them to stop the drug in many cases. 6 patients went on to have further surgery. 3, fortunately, were globe-sparing procedures, but unfortunately, 3 patients still needed exenteration. If we move now to squamous cell carcinoma, targeted therapy has a role here too. Epithelial growth factor is a transmembrane receptor protein strongly expressed by SCC. Cetuximab is a monoclonal antibody which inhibits the downstream kinase activation, whereas allotinib is a tyrosine kinase inhibitor. And a more recently developed drug, cemiplimab, inhibits PD-1, program death 1. This is one of Beta Esmaili's patients who showed a good response to allotinib. I have not used this myself, but we have experience with cemiplimab in metastatic squamous cell carcinoma. This gentleman had extensive metastatic disease. This is him 3 years ago. He's still alive today with resolution of his metastatic disease on cemiplimab. This patient had extensive recurrent intraorbital disease post maximal dose radiotherapy with radionecrosis, and his top CT scans show the tumor pre and 3 months post cemiplimab. Similarly, his PET scan, this is his clinical appearance after that. His PET scan in the upper images show the pre-appearance here, and the post-appearance below. Melanoma is a slightly different story. We tend not to use these drugs, checkpoint inhibitors or targeted therapy for primary lesions, but this woman had an extensive metastatic lesion, and she's about to start some of the checkpoint inhibitors for this disorder. With regards to Merkel cell, programmed death L1 expression has been shown, PD-1 expression has been shown in Merkel cell carcinomas, and both avelumab and pembrolizumab have been approved for this by the FDA with good results. These are the melanoma pathways. My slides are a little out of order. I apologize for that. And in terms of checkpoint inhibitors, there are a number that are used. Generally, ipilimumab is used initially, and Pembro and Nivo and Devro are used subsequently. This gentleman had a large Merkel cell carcinoma, and while he did well with local resection, he had extensive metastatic disease. He started pembrolizumab in March of 2018 and is still alive and well as of last month. So in essence, in a short period of time, I've tried to take you through a number of the different targeted therapies for eyelid malignancy, which have applications in our most common tumor, basal cell carcinoma, squamous cell carcinoma, less so at this stage in sebaceous carcinoma, but importantly in metastatic melanoma and Merkel cell carcinoma. Thank you for the opportunity to participate in the All India Ophthalmic Society Ocular Oncology webinar. Thank you.